Deciding on treatment for prostate cancer. This is one of a series of videos that can be found on the website aboutcancer.com that talk about various aspects of cancer treatment. Are we overtreating or undertreating men with prostate cancer? How do you balance the aggressiveness of the cancer versus the patient's age and other medical problems to determine whether or not to proceed with treatment? The things that might affect the decision to treat include the biology and extent of the cancer, how aggressive and how far is it spread, versus the health status of the patient, their life expectancy, and their other medical problems. It's been known for years under biology, the more mutated the cancer cells are, the lower the cure rate. So as these graphs show, well-differentiated cancer may have an 88% long-term survival, 70% if they're moderate or medium, and only 50% if they're poorly differentiated cancer cells. The National Comprehensive Cancer Network, or NCCN, has detailed advice on how to treat cancer, and I strongly recommend patients go to this site or ask their doctor to review the current NCCN treatment guidelines with them. If you go to the NCCN, by 2018, they now have at least 8 different risk groups for prostate cancer. And unfortunately, you have to know how to review all these categories to make a good determination or decision on treatment. And I will briefly walk you through these. The first thing is to know the stage of the cancer. This is typically referred to as the TNM system, the tumor size or extent, the lymph nodes, and any evidence of metastases on a CAT scan or a bone scan. The histology report, or the path or biopsy report. These are almost always adenocarcinomas, but what you want to know is the Gleason score or grade, or some measure of how mutated the cancer cells are. And then the staging system also includes the PSA level. And you'll note there's a break point here between a PSA less than 10 or a PSA greater than 20. All these things are then combined. The Gleason score is based on a pathologist named Gleason who scored this from 1 to 5, 1 meaning the cells almost looked normal, 5 the cells were very mutated and very dangerous or rapid growing. This is the Gleason pattern. He then said score it twice and add it up. That's the Gleason score, so that would be 3 plus 3 or 4 plus 3. And they've now created something called the grade group, where you then take the Gleason score and put that into one of these 5 groups. The PSA, or prostate-specific antigen blood test, is quite well known to patients. And the point is here, with surgery, the cure rate drops dramatically once the PSA is over 10. With radiation, similar data. The PSA results, if it's over 10 or over 20, the cure rates drop dramatically. So balancing the aggressiveness of the cancer is the life expectancy of the man. There are typical life expectancy median tables as noted here. I would make an obvious point. The average 62-year-old patient lives 20 years. The average 76-year-old patient lives 10 years. And the average 87-year-old man lives about 5 years. You can adjust the life expectancy based on the patient's overall health status by as much as 50% as noted. So for instance here, if you have a 70-year-old man who's very healthy, his life expectancy is almost 20 years. An 80-year-old man who's very healthy, 11 years, and even a 90-year-old man who's in very good health, his average life expectancy is almost 6 years. And then the obvious thing from this graph, survivals are often quoted as a median survival. That means half the patients live less than that and half the people live longer. So what are the treatment options here? We used to use the word watchful waiting. That's been changed to 2 words, observation, which means you simply monitor the man until symptoms develop or the PSA is sky high and then offer him just palliative hormone shots, or active surveillance, which means you check the man closely every 6 or 12 months, and if there is disease progression, you do offer him curative treatment, either surgery or radiation. And monitoring this could include a PSA, a digital exam, an MRI, or even a repeat biopsy may be necessary. If you do proper active surveillance, as in these recent American trials, the probability of dying of cancer should be extremely low. The 10-year prostate survival numbers here, 98 to 100%. But at the same time, between a third and a half of the patients ultimately end up being converted to active treatment, meaning they received either radiation or surgery. So how does the NCCN divide patients up and put them into these risk categories? The best group is called very low. They have an early stage, a T1C, meaning you can't even feel it, a Gleason group of 1, which means the score was 6, PSA still less than 10, less than 3 fragments of cancer, so very small volume. And so what they recommend, if the patient is older with a life expectancy less than 10 years, which means they're 76 or so, then just observation. If they're a bit younger, then you do active surveillance. And if they're really young, defined as a 20-year life expectancy, so a man in his 50s or early 60s, then along with active surveillance, they say you can consider going ahead and offering the man surgery or radiation. Low risk is the same, an early stage, a Gleason 6, but a higher volume. Here now they say consider genomic testing, which I'll come to in a minute. But in the low risk category, if the man is older, less than 10 years, they still recommend only observation. If the man is younger than 76, they say consider active surveillance, or you can go ahead and offer him surgery or radiation. The next group would be called favorable intermediate. So the stage is a little higher, T2, you can feel the lump. The Gleason is a little higher, group 2, which means a Gleason 7, calculated as 3 plus 4. And the PSA is still relatively low, less than 10. They also say consider genomic testing in this group. And the treatment options here, again, if the man is older, less than 10-year life expectancy or over 76 years old, they still list observation, but now they do include going ahead with radiation in that group, generally not surgery for a man that old. For a younger patient with a 10-year life expectancy or greater, they now change the advice to active surveillance or surgery or radiation. The next group would be called unfavorable intermediate. The Gleason group is a little bit worse now, a 2 or 3, or the PSA is a little bit higher, 10 to 20. And now again, they say if the man is older, 76 or so, observation or radiation, but now radiation is generally given along with 2 hormone shots, 4 to 6 months of Lupron. If the man is younger, they offer surveillance or surgery or radiation. And again, radiation in this group, it generally is combined with 2 Lupron shots. The next higher group is called high risk, so a T3, meaning the cancer's already gotten into the seminal vesicles, or the Gleason group is higher. The Gleason score is now 8, 9, or 10, or the PSA is over 20. And they have a group called very high that has even slightly worse scores. Both of these groups, if the man is very old, meaning less than 5-year life expectancy, which would be basically 87, then they recommend observation and giving them hormones if they need it. If the patient is anything younger than that, they do recommend going ahead with either surgery or radiation. And interestingly, now the radiation should be combined with 2 or 3 years of hormones or Lupron shots. Starting in 2018, the NCCN also added the word genomics in the decision process. And on the table for the 2 groups, low risk or favorable intermediate, you can see now they list molecular testing of the tumor. So what does that mean? A genomic test means evaluate the activity of genes in the tumor that have been shown to be involved in either development or progression of prostate cancer. And as I dictate this in 2018, there's at least 4 or 5 of these that are commercially available, and insurance generally pays for them. Decipher will give you risk numbers. The reports will look like this, high risk or low risk. Oncotype DX for prostate will do the same thing. Prolaris will give you a score, and ProMark will also give you a score. Also in 2018, Spratt published a paper where he said combine the NCCN score and add in the genomic score from Decipher and create a new combined category. This provides better predictive outcome than the NCCN groupings as shown. So for instance here, there's a clear separation between the risk groups, low, intermediate, or high, in the development of metastases. Also note on this graph that most of the problems don't show up until well after 5 years. So it's in this 10 to 15 year period that most of the problems will show up. Similarly, they could break this down into all 6 categories, as you can see from these numbers. Now, if you say, well, what's the benefit of that? How is this helpful? Well, if they have a very low 10-year risk of metastases, 3% or so, then you may want to do even less active therapy. But if their risk of metastases is 25 or 30%, you may want to be doing even more active therapy. And if their risk of developing metastases is really high, here 50 to 60%, you probably should offer the patient a lot more therapy, perhaps including chemotherapy or immunotherapy. And again, notice here on these survival graphs for cancer mortality that with a low-risk patient, the odds of ever dying of cancer is only 2%. But with the other groups, it's higher. And again, notice most of the deaths don't show up until 10 to 15 years. And all this should be factored into treatment decisions. Also notice from this complicated graph that if you do the genomic testing, 2/3 of the people were put in the wrong class, and you have to shuffle this all around. If you take one of these out, the favorable intermediate group here, based on the NCCN scoring, after you've done genomics, you find that only 28% of the people were put in the right group. 44% were really lower risk, and you're probably over-treating them, and 27% are in a should have been moved to a higher, more unfavorable group, and perhaps you've been under-treating them, so the genomics may really make a huge difference going forward. If this is too complicated, again, get your doctor to walk you through the NCCN guidelines or explain whether genomics would be helpful. There are websites where you can do calculators or so-called nomograms. There's a nice one from Memorial Sloan Kettering, as shown here. There's a nice one from Johns Hopkins, shown here. If you go to my website, I have a link that groups all the prostate cancer calculators that I think are useful. And finally, you can go to my main website, aboutcancer.com, and review all this material. You can go directly to the video site as noted, or directly to the YouTube site as noted. All this, again, can be found on the website, aboutcancer.com.